All right. Well, we'd like to welcome everyone out today. It's my pleasure to give this presentation on shock. Before I start the presentation, though, I just want to send out a thank you to all of the EMS providers that are both in the area here as well as wherever you may be today. You are definitely the eyes and ears and the hands of those of us who work in the hospital, and a lot of credit goes to you for saving many lives, and I just want to thank you for that. Today I want to talk about shock, and what I'd like to do today is cover several different types of shock, as well as then focus on hypovolemic shock. So we will go through many different kinds. We'll talk about the presentation of these different types of shock, a basic look at how to treat the shock, and then we'll go into a little more detail on fluid management also. I've really tried to gear this presentation to out of the hospital, so out in the field where you come across the patient initially rather than in the emergency department. So first of all, let me get on here. So the objectives of today is first of all, I'd like to define, one of the objectives will be to define shock. Another one will be to understand the basic pathophysiology of shock and the different types of shock that you'll see. At the end of this, I would hope that you would understand the basic treatment goals for shock, as well as how to differentiate between the different types of shock, and then understand the initial treatment for hemorrhagic shock. And for those of you who are here in Salt Lake, I would appreciate any comments or questions that you have. So please feel free to stop me at any time and ask questions, and I'll probably be asking you questions also. So first of all, I want to just talk briefly about what we call the golden hour. And we know that approximately 50% of trauma deaths occur immediately following the injury. And these deaths occur from things like massive hemorrhage, high spinal cord injuries, severe head injuries. And so a lot of these people we can't really do anything about. We can try to prevent the accident from happening in the first place, but in many cases there's nothing we can do when we get to the scene of them. Another 30% of trauma deaths occur within the first 1 to 2 hours after the injury. So these are people that we can make a big impact on if we can get there soon enough, begin our treatments, and then hopefully get them to definitive care. The golden hour basically states that we want to, if at all possible, get our patients to the highest level of definitive care that we can within the first hour. Now, I realize that out in rural areas this can be very difficult. But the goal is to get them to the next level that we can as soon as possible. So we will begin the treatments for shock and the injuries there, and then our goal is to get them somewhere where definitive treatment can be given as soon as possible. So that's what I mean when I talk about the golden hour. In order to understand shock, I think it's important to talk about the basic physiology. So the first thing that I want to mention is preload. Does anybody here know what preload means when I'm talking about preload?
It's the volume that you have that's returning to the heart.
Okay. Excellent. So preload is basically the volume of blood that is returning to the heart, or we could also say it's the end diastolic volume or the amount of blood in the left ventricle right before systole occurs. This is important because if we don't have any preload, then we're not pumping any blood. So we've got to get the blood back to the heart in order to oxygenate it and then get it back out to the body. The second important part is afterload. Does anyone remember what afterload is?
It's basically, you increase your afterload by vasoconstriction, you decrease your afterload by vasodilation, so it's the resistance that the blood has to push against. The heart has to push the blood out against.
Okay.
To the tissues.
So that's perfect. It's the, like you said, it's the resistance that the heart is having to pump against. Or it's the resistance that the preload is having to go against to get out to the body. And so, like Russ mentioned, this can be related to vasoconstriction. So if your vessels are vasoconstricted, then you're going to have an increase in preload. Now, an increase in preload can be good in some cases and bad in others. In terms of shock, an increase in afterload can be good in some and bad in others. In terms of shock, this increase in afterload, the body will attempt to vasoconstrict in order to try to get the blood to the most important areas like your brain and kidneys and heart. So in that case, it can be a good thing. Now there's one type of shock, neurogenic shock, that we'll talk about a little later, where you lose that afterload. You get a massive vasodilation, and the same with septic shock. And so you have almost no afterload, which is also a problem. In your chronic patients, we could think of afterload like hypertension or high blood pressure. So for most people, high afterload is a bad thing. And in shock patients, we want to try to adjust that afterload if possible to provide the best blood flow to the organs that we can. The next part is cardiac output, and this is simply your heart rate times your stroke volume. Now your stroke volume will be dependent also, once again, on your preload as well as your afterload. So the higher preload that we can get in these patients and get it out to the body, back out to oxygenate the tissues, the better off. Many times, though, in our trauma patients, if they're bleeding, they may not have a good preload. The blood may be on the floor or on the street rather than within the vessels. So our body will take over and try to compensate through the use of our heart rate. So as we'll look a little later, in most of these patients, we'll see an increase in heart rate as they're going into shock, and usually, in most cases, a decrease in their blood pressure. So it's important to understand these principles before we talk about the different types of shock. Do any of you here have any questions up to this point? Okay. So let's first of all define shock. Shock is basically defined as an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation. So basically, when a patient is in shock, their cells at the cellular level are not getting the oxygen that they need or the nutrients that they need. And as we know, that can't go on for very long. After a few minutes of depleting the cells, then the cells no longer work how they should. So the goal with the treatment of shock is always to try to get blood and oxygen and nutrients to those cells that need it the most at the time. In most cases, that's going to be the brain and the heart and the kidneys in some cases also. So that's what we're looking at when we're talking about exactly what shock is. So I'd like to take a few minutes now and talk about some different types of shock and how they are treated. And we've got some people from AirMed here, which I think will be helpful because you can give us some ideas on what you do specifically in the field for some of these different types. So the first, we'll talk about hemorrhagic shock, tension pneumothorax, cardiogenic shock, neurogenic shock, and septic shock. So the first one I want to talk about is a tension pneumothorax. And a tension pneumothorax occurs when you have basically a one-way valve going into the chest. So for some reason you've had an injury to the chest and you've got air going into the thoracic cavity. But there's no way for that air to come out of the thoracic cavity. So each breath you take, you're actually sucking air into that cavity, and it creates a huge amount of air and a huge amount of pressure within the chest. Does anybody here know what it is about a tension pneumothorax that is so deadly?
It's basically the pressure builds up so much that it shifts the heart, the lungs over to one side, twisting the aorta and cutting off circulatory, the blood flowing to the other organs in the brain and stuff like that.
Okay, very good. So he said that there's a large amount of air that creates pressure within the chest and begins to push the structures within the chest, like the heart and the lungs, to one side of the chest. Now, a lot of people think that the main issue here is that we're cutting off arterial flow. In reality, what we're cutting off is venous flow. So it's the flow of the blood coming back to the heart through your big vessels like your superior and inferior vena cava. If you think about an artery is very muscular and distensible. It's hard to collapse it. But the veins are very thin, and they rely on blood or fluid being within the veins to keep them open. So in a tension pneumothorax, you're basically dying of circulatory failure because you're not getting blood back to the heart. Or in terms like we talked about earlier, you're losing your preload. Your preload is then gone. So the signs and symptoms of a tension pneumothorax are obviously, first of all, respiratory distress. I have yet to see a person with a tension pneumo that is just sitting with me comfortably talking and wanting to talk about the Jazz game or whatever score it might have been the night before. They may also have some subcutaneous emphysema. So when you palpate their chest, you'll feel almost like little air bubbles, like you would in the packing material that you use that the kids always like to pop. You'll feel that within the tissue itself. If you're doing percussion, which my guess is you're not doing percussion in the field, as you're trying to get the patient out of the car or whatever it may be. But if you did do percussion, you'd have a hyperresonance, just because you now have a huge amount of air in the thoracic cavity. They will also have a late sinus tracheal shift, and they will also have absent or severely diminished breath sounds on the side of the tension pneumothorax. Yes?
There's an exception in that breath sounds are not always diminished on that side because their chest is so small.
Okay. So Russell just said that in pediatrics there's a difference in that they may not have those absent breath sounds because the chest is so small. Excellent point. So the question here is what can we do now to treat a tension pneumothorax? And this is where I would defer to our air med people in what you would do for a tension pneumo.
So for immediate relief, we'll usually do a needle.
Okay.
Then proceed with the chest tube.
Excellent. So for immediate relief, you would put in a large bore needle to that side of the chest, second intercostal space, mid-clavicular line, to relieve that air. Now, as soon as you do that, that is going to buy the patient a chest tube. So once that has been performed, wherever you can get them that they can perform a chest tube, it needs to be performed. And in some of the providers like AirMed, LifeFlight, the highly advanced areas, they can do that in the field. But in many cases, your goal is going to be to get the needle in, relieve that tension, and then get them to someone who can place a chest tube. Now, one thing I want to mention on this is I don't know if any of you are serving any areas where all of your patients are very thin and everybody is a marathon runner. I don't think that's the case. I think in most cases we're seeing patients that are larger and larger. And I remember seeing a case several years ago where we had a patient come in who had a tension pneumo. He had been needled bilaterally, but because of his size and weight, the needle never actually made it into the thoracic cavity to relieve the pneumothorax. So it's important that you're not just using a little 1-inch angiocath, but make sure that you have longer angiocaths, and you want to talk to your agencies to determine how big you can have. But it is becoming more and more of an issue in treating these patients. The angiocath just going into the muscle or the subcutaneous fat is not going to do any good. You've got to get into that thoracic cavity to relieve the air.
So now, are you guys using what, 16s?
14s, 3 and a quarter.
Okay. So they're saying they're using 14 gauge, 3 1/4 inch for that. And you should get an immediate rush of air once you put them in. I like to think of it, I don't know how many have been raised on farms or seen cattle where they get bloated and they stick the trocar in and relieve it. It's similar to that. You should get an immediate rush of air. So the next one is cardiogenic shock. We normally think of cardiogenic shock as being a primary cardiac issue, patients that have had an MI or patients that have severe heart failure. But in terms of trauma, there are several different things that can actually lead to cardiogenic shock. The first one is any blunt cardiac injury can cause cardiogenic shock. Cardiac tamponade can lead to cardiogenic shock, and we'll talk about tamponade in just a minute in a little more detail. Patients with an air embolus may also develop cardiogenic shock. And then also any patient who has had an MI or is experiencing an MI during their trauma could end up in cardiogenic shock. So the basic pathophysiology of this, and I've put this on the slide for you, is you'll have a decrease in cardiac contractility, which means that for some reason the heart is not able to pump and squeeze as hard as we would like it to squeeze. They'll have a decrease in stroke volume and cardiac output. So if it's not squeezing well, it's not going to be able to pump that blood that's in that left ventricle and get it out to the body. So your cardiac output will go down. Many of these patients, if it continues on, will develop pulmonary congestion. The blood will actually back up into the lungs rather than being sent out to the body. You'll have decreased systemic tissue perfusion. So once again, you're at the point of you're not getting the nutrients and the oxygen to the cells that need it. And then you can also get a decreased coronary artery perfusion. So if your heart isn't working well and your coronary arteries aren't getting blood, then your heart is going to work even worse, and you can end up with, if they haven't already had an MI, basically you'll end up with an ischemic heart once again. So that's the basic pathophysiology behind cardiogenic shock. Do you have any questions on that? Anyone?
Not a question. I noticed you had the air embolus up there, and I've seen it a few times where sometimes EMS they'll put the fluid under pressure bags, and they get it's getting down and down, and they'll just keep on inflating it, and you have that pocket of air. If they don't take that out beforehand with the pressure bag, I've actually seen a few patients get air embolisms from that.
From the actual pressure bag coming in.
Pressure bag shoving it in, and then they end up having like a Millhouse murmur with it. But then they'll have chest pain and shortness of breath that goes along with it, because they get that bubble of air that goes into the heart.
Okay. Very good. So Russ just said if you couldn't hear him that he's seen air emboli before from pressure bags where they put the pressure bag on, they don't bleed the line appropriately basically, and continue to push air through the tubing, and it ends up building up in the heart, and they'll present with chest pain. So that's probably not as common as the others, but it is a possibility that we need to be aware of. So thank you. So let's look at cardiac tamponade. I want you to think of the heart, and around the heart you've got a sac that contains a very little bit of fluid. Now there's two walls to this sac. There's one wall that sits right on the heart. Then there's a small layer of fluid above that, and then another sac that encloses it. In a cardiac tamponade, what happens here is the blood, or that little sac, becomes filled with blood. So normally it should just have a little tiny bit of fluid in it, but in this case it fills up with blood, which puts more pressure on the heart. Now a problem that we have here is, as the heart is trying to fill, so when we go back to talking about preload, we're trying to get our preload up or get blood back to the heart. The heart is no longer able to stretch to allow that blood to get back into the heart. So we end up with a heart that isn't filling well with blood, and then is unable to contract as well to pump the blood out. So the signs and symptoms of a cardiac tamponade include tachycardia. And if you remember, when we go back to cardiac output, one of those things that we looked at was our heart rate. So our heart rate is going to go up in an attempt to try to get more blood out to the body. They'll also have muffled heart sounds, and if you think about it, if you've got a lot of blood sitting around the heart, you're going to be listening through liquid or through fluid when you're trying to hear those heart sounds. You'll also have dilated and engorged neck veins, and that comes about because the blood is unable to get back into the heart like we talked about, and it ends up backing up, just like you'd see almost in a heart failure patient. And then these patients are usually, they have hypotension or low blood pressure, and they're resistant to fluid therapy. So you're giving them fluid, and it's not doing any good. They're still tachycardic. They're still very hypotensive. The only way to relieve this is you need to remove that blood that's sitting around the heart. And tell me with AirMed, do you do anything with needles to that area?
We do the pericardial
Okay.
At that point, it's a last ditch effort.
Okay.
Severe tamponade, very little surgical intervention.
Okay. Okay. And I agree with you. I've seen they'll attempt pericardiocentesis, or they may, but they said here that that's kind of a last-ditch effort. And I've seen the same thing in the emergency department. Everything else has been tried, and then they go to that. So if your patient truly has acute onset cardiac tamponade, they're in a world of hurt, and you need to do something fast. However, in most cases, it may be a little too late. So, Russ.
And the interesting thing with that, too, is that, I don't know, I've seen it when they take the blood out and they actually have a tamponade, is one of the anomalies you see is just interesting is that the blood doesn't clot.
Mm-hmm.
And that it has, I think it has something to do with an enzyme or something like that, that is secreted and causes it not to clot, as opposed to if you put it in the ventricle and pull back that blood.
Then it would clot.
That would clot.
So Russ said that one of the things that he's seen is when they pull the blood out of a cardiac tamponade, it doesn't tend to clot where your blood normally would clot. So I'd never noticed that, but I haven't seen a lot of them either because we don't do them that often. So that's cardiac tamponade. The next shock I want to look at is a little bit different, and this is what we call neurogenic shock. Now, as I was reviewing the ATLS manual for this presentation, I wanted to read a little bit about neurogenic shock and what they say. One of the bolded statements in the ATLS manual states that isolated intracranial injuries do not cause shock. So just because they have a head injury doesn't mean that they're going to have shock. So we also need to be looking for other reasons for shock if they do have a head injury. The classical presentation of neurogenic shock is a little different than the others. We talked in the other shocks so far, the patient becomes tachycardic. In neurogenic shock, we have hypotension without tachycardia and without cutaneous vasoconstriction. So these patients are vasodilated and they're not tachycardic. The reason for that is we lose sympathetic tone when we're in neurogenic shock. So normally the body would try to clamp down to keep the blood pressure up. In this shock, it doesn't clamp down, and we lose also the sympathetic response from the heart in pumping faster. So a key here, and we'll talk about this later, but once again, in neurogenic shock, a big key is going to be to immobilize the spine and to give fluid to try to fill up those vessels as much as you can before they can do a definitive treatment. So that's all I want to say about neurogenic shock. Do any of you have any questions or comments regarding it? Yes?
Usually part of the treatment too is we'll start them on a pressor.
Okay.
Just to combat that loss of sympathetic tone.
Okay. Okay. So he said that a little different treatment here. In most cases of trauma, you're not going to put them on a pressor. You're going to give lots of fluid. In this case, you may start a pressor in the field if you're able to do that to try to increase that sympathetic tone to get the blood pressure up and to get the heart rate, the heart to pump stronger and faster. So, excellent. The next one I just want to mention is septic shock. Septic shock is going to be uncommon in an acute injury. So a patient that you pick up at the scene of the accident usually isn't in septic shock. However, That being said, if the transport has been delayed for any amount of time, these patients can actually develop septic shock. And the treatment of septic shock is a whole other 1 or 2 hour lecture, so I'm not going to go into a lot of that other than give fluids, give fluids, give fluids, and get them to definitive care as soon as you can. In terms of trauma patients, the most common cause of shock is going to be hemorrhage. And hemorrhage is defined as an acute loss of circulating blood volume. We also may call this hypovolemic shock. So throughout this lecture, I may refer to it as hemorrhagic shock or hypovolemic shock. In either case, I mean the same thing. I think the take-home point here, though, is for any trauma patient, we have got to suspect hemorrhagic shock if they're in shock, first of all. Because in most cases, or in many cases, that's what they're going to be experiencing is from hemorrhage. The basic pathophysiology of hemorrhagic shock is we have a decrease in blood volume. So the blood has left the intravascular space and gone either somewhere into the body or out of the patient. So we're losing that overall blood volume. This leads to a decrease in venous return to the heart. So the blood that would normally come back to the heart to create that preload like we talked about is no longer available to do that. Because of that, we have a decrease in stroke volume. So each heartbeat is going to pump out less blood, which leads to an overall decrease in cardiac output and decrease in tissue perfusion. So once again, we're back to those basic principles of preload and heart rate, stroke volume that are all playing into this patient. So I want to talk about some areas where you can put enough blood to die. A lot of people, their first answer is the head. Well, it's true, you can put blood in your head, but you're not going to bleed to death inside your head. You're going to have a huge amount of pressure in your brain, obviously, which can lead to death, but you're not actually going to exsanguinate into your skull cavity. Okay? So we usually don't mention that one. But the next one is in the thorax, and if you think about it, that's a huge area of the body, and you can put enough blood in your thorax to actually bleed to death. And this would show up like a massive hemothorax, and this can also cause a tension, it could cause the same symptoms like a tension pneumo, but it's actually blood causing it. The next area is in the abdomen. So with abdominal injuries, we can bleed enough into the abdomen to actually die. So as you're assessing your patients, you're going to want to be assessing the abdomen. Is the abdomen tense? Are they in pain? And try to determine if maybe that's an area that they're bleeding. The next area is in the pelvis. And when you think about the pelvis has huge veins running through it. And if you have a pelvic fracture and you're shearing those veins, then you have, once again, a huge amount of blood that will just pool in the pelvis and is never going to make it back to the heart to get pumped out once again. Another area is in your thighs. So you can put a lot of blood. If you had bilateral femur fractures, you could put a lot of blood in your thighs also. And then the last one that we talk about is on the floor. And this is usually the most common that people, well, I don't want to say it's the most common, but it's usually the most dramatic, where people will come on the scene and they'll see blood all over the place where it's come out of the body and is somewhere else. But we do need to remember that these other areas within the body are just as important as the blood that we see on the road or wherever it is that we pick up the patient.
You know, the other thing
Yes?
with it, I mean, we talk about blood loss, but you don't lose blood with burns, but in essence, it's like hemorrhagic shock.
Mm-hmm.
You're losing volume, you're going into the tissue space
Mm-hmm.
as opposed to that, so you don't have that preload there with that. So burns can be the same
Mm-hmm.
way.
That's an excellent point. So Russ just said that with burns, we may not be losing a lot of blood, but the tissue that's normally within the vasculature area, what we call third spaces and goes into the tissue, and we lose it within the vessel. So once again, we lose that preload and that ability to get blood out to the body. So that's an excellent point. Now, when you're seeing a patient in the field, I wouldn't expect that you would carry this little chart around and try to figure out exactly where they are in terms of their blood loss. But I wanted to show this chart to show you some of the signs and symptoms that you may see when you're treating patients who are in hemorrhagic shock. So class 1 of estimation of fluid or blood loss, this would be about like giving blood. So you've gone down to the Red Cross, they sat you down, they stuck a needle in your arm, they drew your blood, they gave you a cookie and some orange juice, and you were on your way. This is usually less than about 15% of your total blood volume that's lost. Your pulse rate is usually going to be less than 100. Your pulse rate may be over 100 when they poke you, but once you relax, your pulse rate's going to go back down, hopefully. Your blood pressure should remain normal. Your respiratory rate would be somewhere between 14 and 20, which is normal. Your urine output should remain normal also, so greater than 30 milliliters per kilogram per hour. You may be slightly anxious, and the fluid replacement in this type of patient would be you would give crystalloid. The next one is class 2, where you can have approximately 750 to 1,500 milliliters of loss. That's around 15 to 30% of your blood loss. Your pulse rate's going to start going up, so you're going to be at probably over 100 when this occurs. Your respiratory rate will probably start going up also as you're attempting to get more oxygen to the cells, so you're breathing harder. Your urine output is going to go down, and these patients are usually mildly anxious also. Once again, the treatment for this would be to give crystalloid. In class 3, this is where they're getting a lot sicker. And remember that they can start in class 1 and move to class 4 pretty quickly. So you want to keep a close eye on them. So class 3 is going to be about 1.5 to 2 liters blood loss. You'll see their heart rate going up greater than 120 in many cases. Their blood pressure's coming down. So heart rate's going up, blood pressure's going down. They're breathing harder, their urine output is going down, and they're becoming anxious and confused. These are the patients that you're going to want to begin with crystalloid and then begin to give blood as soon as you possibly can. And then the last one, class 4, is obviously a medical emergency, which I would consider class 3 also the same, but this is becoming even more and more dire. This is greater than 2 liters of blood loss. Excuse me. At this point, you've lost greater than 40% of your blood volume. Your heart rate's usually greater than 140, and your blood pressure is going down and down. And these patients are confused, they're lethargic, and they're very, very sick. So in these patients, you're going to want to, once again, give fluid as fast as you can, and then begin to give blood as soon as you possibly can get the blood to give them.
Yeah, I had a patient one time at LDS that kind of reminded me of this hospital. And the patient came in, had all this chest injury, abdomen injuries, and we were just focusing on that. And he had a scalp laceration, and he went through all these stages until we figured out when he was actually at class 4, he dumped 4 units of blood into the kick bucket down below him, and he was gave him fluids, came right back up and put direct pressure on it, and it stopped our problem. And the same is true of the patient we saw this morning. The patient's bleeding out, but they put a tourniquet, and it stopped the bleeding, and the patient came right back, responded.
Very good, very good. So he talked about a couple patients, one that they were so concerned about the abdomen and chest injuries that they weren't really looking at the scalp lac, and then they realized at the end that he was actually bleeding out from a scalp laceration. So that's why it's so important in trauma to look at everything. Don't just figure you've got it in one spot, but be looking at other areas too, because like the scalp can bleed like crazy. So this patient could have died from basically a scalp laceration if it hadn't been noticed. So we talk about the 3-to-1 rule, and my guess is in the field you're not going to go out and measure all the blood that's going to come out and then try to replace according to this rule. But there is a rule that they talk about, and it's a rough guideline for the amount of crystalloid volume acutely required is to replace each milliliter of blood loss with 3 milliliters of crystalloid fluid. And according to ATLS, the preferred fluid is Ringer's lactate for big resuscitations. Now, different places may use NS, but according to ATLS, they recommend that. And I think it's because of when you're giving large amounts of NS, you end up putting the patient in a metabolic acidosis, basically. So I'm not going to expect any of you to measure the blood coming out and then just do a 3-to-1 thing. But you want to give fluid and then watch their signs and symptoms and see what that's doing, rather than trying to calculate the fluid. Another, what I believe is a take-home point of this lecture is always remember your ABCs. A lot of people will come on the scene of an accident and they'll see the broken arm. And to them, the broken arm is the most graphic thing, and so it's probably the worst injury that the patient has. When in reality, they could have massive other injuries that are actually going to kill the patient. So for that reason, ATLS, you'll always want to run through your ABCs. The thing I love about the ABCs is you can run a trauma, you can run a code. I use it to read chest x-rays, and I use it to do a lot of different things. So the other thing that it helps me with is when I come on a patient that's sick, it lets me stop for a minute, say, okay, if I know my ABCs, then I can do this. And I would encourage all of you to do the same when you're in the field. When you come on to that patient, stop for a minute and work through your ABCs. And remember, with your ABCs, you're not going to move on to A until you've taken care of B, and you're not going to move on to C until you've taken care of A and B, unless you're in a big group and you can do them simultaneously. But the first one is airway and cervical spine. So on any of these patients, you want to make sure that they have an adequate airway and that their cervical spine is immobilized. The next one is to make sure that they're breathing. So you're going to want to check, see if you can physically see them breathing, listen to their chest. And once again, this is where you're going to pick up things like attention pneumothorax, because they're going to lose those breath sounds, and they're going to be having a really difficult time breathing. The next one is circulation and hemorrhage control, and this is where hemorrhagic shock comes in. So you want to make sure that they have pulses. You want to do everything that you can, if you know that they're bleeding somewhere, to stop that bleeding. So for instance, we had a patient this morning who came in who had a partial amputation of his arm. And I was very impressed that the patient and whoever was with him knew enough to put a tourniquet on right when it happened and to leave that tourniquet on. So they put the tourniquet on, applied direct pressure, and with that, eventually were able to stop the bleeding. We were expecting massive bleeding when they came in, but we got here, they actually took the tourniquet off, and it had tamponaded, and he was able to restore blood flow to his tissues. So whoever that provider was did the right thing in controlling the hemorrhage right off. The next thing you'll always want to look at is disability. Do a quick neurologic exam. And once again, when we talked about the amount of blood loss, we talked about that confusion, mental status changes may also be a symptom of this. And then exposure. Now, I realize that in the field you're not going to cut all the clothes off when fully exposed. You do want to keep the patient warm, and then once you get them to the emergency department, then the clothes will need to come off so you can do a thorough exam and make sure you're not missing areas that you would not see because they were under clothes. So the treatment goals for hemorrhagic shock are, once again, follow your ABCs, control any obvious hemorrhage in whatever way you can. That may be direct pressure, that may be tourniquets. The next thing is to, as soon as you can, insert 2 large bore IVs, at least 16 gauge or larger. Usually they're put in the anacubital areas if you can. And you want to get that going as soon as possible so that you can move on to the next part, and that's administering the IV fluids. Oh yeah, I didn't put that on, but you could use IOs also if you need to, if you can't get IV access. That's an excellent point. And I don't know, are your IV fluids warmed? Do you have warmed fluids in the helicopter? Or are they just kind of air temperature?
One of the helicopters has the capability of warming, but the others are just temperature.
Okay. So, you want to give what the warmest fluid that you can, and that may be air temperature. If you are lucky enough to have warm fluid, then you'll want to give that. But you do want to keep that patient warm, because we know that as the patient gets cold, then they have more problems with blood clotting. So, initial fluid therapy, I already mentioned you want to use Ringer's lactate, which is the fluid of choice, unless your specific agency is using NS. You want to give warmed fluid as rapidly as possible. And as I said earlier, the amount of fluid required for resuscitation is difficult to predict. So that chart that I showed you, you're not going to be able to, just figure out how much blood came out and give that same amount back in fluid. But you're going to need to watch the patient. You'll want to assess the patient's response to the fluid resuscitation, and then assess for end organ perfusion and adequate oxygenation. So make sure, if at all possible, that they are getting perfused. So here are some of the things that you can watch for. I think a lot of times when patients are in the hospital, we talk about end organ perfusion. And we talk about it a lot in the ICU. I don't know how much it gets talked about in the field. But these are simple things that you can look at to give you an idea of, are they being perfused well enough? The first one we already mentioned is mental status. Are they confused? Are they getting more and more confused? Or are they completely with it and doing okay? Looking at their vital signs. Are they tachycardic? Are they hypertensive or hypotensive? You can assess that. You can look at their skin color and temperature. Are they cool and mottled? Or are they warm? Are they clammy? These are all end organ things that you can look at. And then the next one is, if you have a Foley catheter in, then you can look at their urine outputs. So an adult should normally have about 0.5 milliliters per kilogram per hour urine output. A child, 1 milliliter per kilogram per hour, and less than a year old, 2 milliliters per kilogram per hour. So this is a great thing that I think is underutilized in many cases, is just watching the urine output. How much is it? What does it look like? I think sometimes in today's world we get so focused on the new technology that we forget to look at the basics, which can give us a lot of information. Evaluation of the resuscitation. Did they have a rapid response, which means their vital signs came back to normal? Was it more of a transient response, where they had some transient improvement, but then they have the hypotension or tachycardia reoccur? Or are you getting no response at all? In the cases of the rapid response, usually the crystalloid is adequate. And when they get to a definitive area, you would want to type and cross-match. They still may need surgery, and it's always recommended that you have a surgeon nearby if you can. Now, I realize that in rural America, there's not a surgeon that's sitting at the doorstep of every emergency room waiting. So, but it is important, if they need a surgeon, to try to get them to an area where the surgeon is available. In the transient response, they're going to need more crystalloid. They may have a moderate to high need for blood, so these patients will probably actually need some blood. You'll want to do type-specific crossing, and then these will likely need some type of an intervention. If there's no response, you need to give emergency blood if you've got it. Otherwise, just keep giving as much fluid as you can and try to figure out also if there's something else going on. Do they have a tension pneumo? Do they have a cardiac tamponade? Are they in neurogenic shock? With continuing with the treatment and then reassessing for the treatment. Yes?
The other thing, another caveat that goes along, we had discussed a patient a few weeks ago, normal blood pressure. Well, in elderly patients, we had a patient came in, gunshot wound to the chest, and his pressure was 90 all the way along until he crashed. Well, 90 for somebody that's 80 years old is hypotension. And that's something, we always say the magic number is 90, but in the elderly, it needs to be higher. And they're also on drugs. It also cause their heart rate not to increase. And so that also can come into the factor when you find out that they're on drugs like medication to slow their heart rate down.
So Russ just made an excellent point about in the elderly, you're going to assess the vital signs a little different. blood pressure of 90 in an older person may be extremely low. Another thing to remember in the older population is that a heart rate of 110 in a 90-year-old is basically more than their maximum heart rate. So you're going to treat that a little differently than you are in your young, healthy person. And then the other thing in the elderly that Russ mentioned is a lot of times they're on medications that are going to slow their heart rates down. So they may be on a calcium channel blocker or a beta blocker, and you're not going to see that tachycardic response because they've taken a medication that is actually slowing the heart rate down. So that's an excellent point. Thank you. So in closing, I just want to share a few of the take-home messages. I think number one is always, always, always follow the ABCs. You will never go wrong in following the ABCs. Number two is that hemorrhage is the cause of shock in most trauma patients. So until deemed otherwise, treat like they're bleeding. The goal of therapy is to restore end organ perfusion and oxygenation. And then always remember the golden hour. Try to get to somewhere where they can receive definitive care as soon as possible. And that's all I have. Any questions from anyone? Okay. Thank you.